a great honor to be here in Israel, here in Tel Aviv, to talk to you about something that is very important for all of our patients. That's why I was willing to fly from the United States to come and talk with you, of course, to see Israel, but because I feel so strongly about what we can do for our patients with this vaccine. I'm going to talk a little bit about the epidemiology. Most of you know this. Most of you, I understand, are in primary care, either family physicians or general internists, some infectious disease physicians with us also. You know that your patients have zoster. 1 in 3 people are going to develop zoster during their lifetime. If you live to 85, you have a 1 in 2 chance of developing zoster. Both the incident and the complication rates of zoster increase as we get older, and it really causes a significant burden. The woman you just saw is not rare, unfortunately. We have lots of women and men, as they get older, who suffer this kind of burden. Zoster, as you know, is limited to 1 or 2 adjacent dermatomes. That's why people think of it as going around in a belt-like. It is a limited area that's affected. It's grape-like clusters. This is different than the chickenpox rash, although it's caused by the same virus. And the lesions usually heal within about 4 weeks. Most of them will crust over, as you know, within a couple of weeks, and the scabs will be there for another couple of weeks. This is really a fascinating virus if you're studying the virus. If you have the zoster, it's not so fascinating. But the virus from the chickenpox stays in the dorsal root ganglia along the spinal column, and for reasons that we don't yet understand, something reactivates the virus. It starts to reproduce again. It comes down the nerves, the peripheral nerves, and then gets to whatever skin area is going to develop the rash. We think that the prodrome, which most of you know about, the people that come in with no rash yet and talk about this very severe pain, this is the irritation of the nerve as the virus comes down, and then the rash breaks out. These are the kinds of dermatomal distributions. All of you know about the dermatomes. If we talk about the lumbar one, these are the cervical spine dermatomes. So that this woman, for example, who was saying she has it on the back of her leg and her lower back, probably has something like L1, maybe L1 and L2. And this is, again, why patients complain of a localized pain and a localized rash. The most common area is on the trunk, the chest, and the upper back, with the face being next most common. This virus is a member of a family of other viruses, you know, that also act in unusual ways. This is the zoster virus. This is herpes simplex. Both of these are alpha-1. This is the human herpes virus family. But look over here. We have Epstein-Barr virus. We have cytomegalic virus. These, again, are viruses you know. Epstein-Barr virus, for example, causes mononucleosis, which is also an unusual kind of condition. So this whole virus family is strange. Zoster is a worldwide problem. It was very interesting to find out all the names for zoster around the world. And of course, I am not going to try to say this, but it means herpetic belt-like rash. Certainly a very good description of what the zoster rash is like. Some of the others are pretty interesting too. St. Anthony's fire, I think that's a pretty good description of what the woman was talking about, the burning constantly. The Norwegians just tell it like it is, hell's fire. In Spanish, a small snake. I'm not sure I understand that one, but you can see that it is a condition that deserves a description in pretty much every language. The worldwide incidence of zoster is shown in this slide, and you can see the orangish one is the UK, the greenish one down here is France. This is one of the US studies down here in purple. This is a study in Taiwan, the white one. This one, of course, is a really great study. That's one of my studies. But you can see all of them look very similar. You have some cases even in very young children, and it increases. But people in the past have said, oh yes, this is a disease of the elderly. And I think of elderly as 80-year-old people. When I was 20, that used to mean 40-year-olds, but now it means 80-year-olds. You can see that this is not a disease that just suddenly jumps right up at 60. It continues to go up, and the increase may be most rapid between 50 and 60 and continues to climb. This is the incidence of zoster in Israel, and you can see the authors down here who have done this study, and you can see there really isn't much, but again, this doesn't start climbing suddenly at 60. This is down in the 40s and 50s already. Almost all of us find that there's more zoster in women than in men. And whether this is truly a difference in gender or whether men choose to ignore it and not come in for health care and women come in for health care, we don't know. But it is interesting that we see it in almost every country that has studied the difference. And then this falling off after the age, this has to do with very small sample sizes in people those ages. This is, again, in the United States, our study, and you can see that there is a difference. The orange and the green, there is a difference. This is women on top and men on the bottom. Again, a gender difference, but the same kind of pattern in Israel and in the United States. One of the things I like to emphasize to people is the importance of the size of these bars. This is the proportional number of cases, and you can see that 65% of all cases of zoster start after the age of 40. And between 40 and 50, which is this one, we have a taller bar than any other age group. The most people who have zoster are in 50 to 59. The reason for that is there are more 50 to 59-year-olds than there are 80 to 89-year-olds. But it is something that I think is important, and because I don't work for Merck, I can say this, I'm looking forward to it being indicated and paid for by insurance in the decade of the 50s. The cases, we also think frequently, well, yes, this is a disease of people who are immunosuppressed, people who have cancer, especially hematological malignancies, lymphomas, leukemias. But that's not true. If you look at this slide, the orange are the people that are immunosuppressed with zoster. The green are the people that are immunocompetent. The majority of people, over 80% of people who get zoster, are not immunosuppressed. So it is not prevention in immunosuppressed that we want, it's prevention in this group. The effect of zoster on daily lives, again, I don't have to tell you about this, you see it in your patients, although I think sometimes we forget when those patients don't call back and ask for pain medicines over a long period of time. we forget that they may be at home suffering without telling us. And you can see people who get pain scales around 3. If you ask somebody, how would you rate this pain from 0, no pain, to 10, the worst pain I've ever had in my life, when they get around 3, they start having an impact on their general activities, work, sleep, and enjoyment of life, and it just continues to climb and get worse as the pain gets worse. We're just finishing up a study now where we're finding that there are a number of people who are up in this 7, 8, 9, 10 range for the first several days of their zoster, but they're not calling back their physician asking for other pain medicine. The healthcare use of zoster is not insignificant. 30% of people who have zoster come in before the rash breaks out, a time that can be extremely confusing. We've had people come in and they've had it on the left side of their chest. A 68-year-old gentleman comes in and he's having severe pain on the left side of his chest. You know what happens to him. He gets admitted to the hospital for a potential heart attack. We had some in our study too, in fact, in our study, who had right lower quadrant pain, and both of them had the shingles rash break out on the incision from their appendectomy 3 days later. So it is a real sort of masked disease in this prodromal stage. Most people make, on average, 3 visits during the time of their zoster. Of course, you have the people who make 1 or perhaps even none, and you have the people on the other end who made 10, 20 over a long period of time. 4% of the cases are hospitalized. Many of these are the immunocompromised people who are getting IV antivirals. 70% of them in the United States anyway receive oral antivirals, most of them within the first 48 to 72 hours. And there is a broad use of opioids, but also antidepressants and anticonvulsants. Most of the HZ-related pain does not respond well to any of those. And the healthcare use, of course, increases with age. The pain duration is kind of an interesting story. The incident of pain, the top line, the yellow one, is pain for 30 days. And you can see as you get older, it starts down in the 20s and it's up in the 80s at this end. You can see as you get older, you're more likely to have pain for 30 days. The orange one is 60 days, and the bottom one is 90 days, what we call post-herpetic neuralgia. The good news for someone who has pain for 30 days is that about half of them will have that pain go away, so they shouldn't give up hope. But you can see as you get older, there's still a very significant 20 to 25% around the ages of 75 to 80 who are going to have post-herpetic neuralgia, frequently lasting for up to a year. The incident of PHN, so this is pain that lasts at least 90 days in Israel. You can see that again, it's very low in the younger age group, starts climbing in the early 40s, and is up around, again, the 20% when we get out here. So very significant. The physiology or pathophysiology of PHN is really an area that a lot of people are studying, but no one agrees at the moment. There's all kinds of theories, from a chronic infection to an irritation of the nerves and the switch over to neuropathic pain. I'm not going to attempt to explain that. Perhaps our pain physician can do that later. Remember that pain is not the only complication of herpes zoster. There are other complications, and this one is a little bit hard to read. I apologize. The green on the y-axis going up is the percent of people from 0, 15% is at the top, coming across are the age groups, pretty much in decades of age, beginning at 22. And you can see the green are eye complications, the orange are neural complications such as muscle weakness. These are non-pain, remember. The blue are skin complications, severe scarring, secondary infection, and then the brown are all the other ones put together. And you can see as you go through, there are significant rates of complications that are non-pain complications as well. The eye complications are particularly bothersome and worrisome to me because you can lose vision and have other problems. This is what zoster ophthalmicus looks like. This is zoster ophthalmicus with eye involvement. There is zoster ophthalmicus without eye involvement. It's the with eye involvement that I think frightens all of us. This is the kind of scarring that you can end up with. This woman basically has very poor vision in the affected eye because she has so much scarring she cannot open that eyelid anymore. The frequency of the complications, this is a paper we just recently published, but you can see of the people who have eye complications, about 75 or 3/4 of them have keratitis affecting the superficial areas, but almost half have iritis and uveitis, the kind of thing that you're going to have fairly intense therapy and a good deal of health care. Recurrences are something that some people question. I happen to believe they exist. We had a group of about 1,669 patients that we followed for over 7 years. And of that group, they had all had an initial case of zoster. 105 of them had one, or there were 105 recurrences in 95 people. The people who had more than one recurrence were all people that were immunocompromised. The recurrence rate of zoster at 8 years was 7.2% for women and 4.5% for men. A little over half of them were in exactly the same site. We didn't notice any recurrences before 3 months, and the ones for the first 18 months or so were primarily in immunocompromised people, but it was about 3 years, 18 months to 3 years, the earliest ones in immunocompetent people. This is the recurrence rate by immune status. As you can see, it's a much bigger problem in immunocompromised people, but in the immunocompetent, it is still a problem, one which can be dealt with by prevention. This is by pain status. People who had more pain for longer were more likely to get a recurrence than those that were not. This seemed backwards to me. I thought if you had more pain, perhaps you would also have more of an immune response and be less likely to get a recurrence. But that's not what our study said, and it's not what other studies suggest either. So in summary, herpes zoster is common. Half of the individuals by age 85. It is a significant problem for people who are still working. It is not only the oldest of the old. It significant lost wages, pain, and healthcare costs. PHN is the most common and most feared complication. The eye complications occur in about 8%, and recurrences are not insignificant. But I think one of the things that all of us know and struggle with is that we don't have very good therapy for treating zoster. The antivirals may have the rash decrease duration by about 1 day. There is no evidence that it decreases the pain duration or prevents post-herpetic neuralgia. And we have terrible therapy for post-herpetic neuralgia. Nobody wants patients on narcotics, opioids, and many of the other neuroleptics, patients have problems taking them in sufficient doses. So we have a disease that's common, we have very poor therapy for it, but the exciting news is with Zostavax, prevention is possible. Thank you.